Gastric ulcers in horses are fairly common, with reported incidences of 2 out of 3 performance horses and 9 out of 10 race horses having gastric ulcers. Gastric ulcers can cause both health issues as well as performance issues. Various clinical signs have been reported, including but not limited to attitude changes, poor performance, decreased appetite, poor hair coat, weight loss or failing to gain weight, and recurrent colic. Although response to therapy may be helpful in diagnosing some cases of gastric ulcers, the gold standard for diagnosis is a gastroscopic examination, or gastroscopy. This allows for complete inspection of the squamous and glandular portions of the stomach, as well as the proximal duodenum. Determining the severity and the location involved will allow the veterinarian to recommend the most appropriate treatments and treatment times. Gastroscopy in horses is fairly non-invasive and can be done in either the clinic setting or in an ambulatory setting with the appropriate equipment and mild sedation. That equipment would include a video endoscope, a video processor with integrated light source and air compressor, monitor, image capture system, suction device, bucket of warm tap water, 400 cc dose syringe, 1 gallon garden sprayer. The endoscope I use is 3.5 meters long and 12.9 millimeters in diameter. It is equipped with a blue air water valve button and a red suction valve button. Placing a finger over the opening of the blue air control vent forces air through the end of the endoscope for cleaning the lens and insufflation. Depressing the blue button fully forces water across the lens to aid in cleaning debris from the lens located at the tip of the scope. The endoscope is equipped with an instrument or biopsy port and channel. Special instruments may be inserted into the channel to take tissue biopsies or aid in foreign body removal. Only insert a biopsy instrument through the biopsy port with the rubber biopsy port cap in place. You can attach a piece of suction tubing to the biopsy port, which will facilitate insufflation, flushing the stomach lining using the 400 cc nylon dose syringe or garden sprayer, and suctioning fluid and air from the stomach. Attaching suction here and not to the suction connector alleviates the potential for plugging the suction channel in the handpiece. Use a small zip tie to attach the suction tubing. It can easily be removed during the procedure if a biopsy instrument needs to be placed. For clarification, we refer to the biopsy channel as the portion of the channel between the biopsy port and the tip of the scope. We refer to the suction channel as the portion of the channel between the suction connector on the video connector umbilical box and the biopsy port. The tip of the scope can be deflected to aid in the exam. Before moving the left, right, and up-down deflection control or articulation knobs, the knob brakes must be released by rotating them in a clockwise direction. The tip can be moved in up, down, and left, right directions by turning the appropriate control knob. Do not force or over-rotate the knobs. In addition to up and down and left and right movement of the tip, the scope can also be rotated on its long axis during the exam to change the view. Appropriate locations for gastroscopy include 3-sided areas such as wash racks or tacking areas, the end of a barn aisle, stocks, inside a large stall, or the corner of an open exam area. The horse is fasted from all feed, including grass, for 14 to 16 hours, and water is withdrawn 2 hours prior to the procedure. Some horses will need a muzzle if they attempt to eat their bedding or manure. The horse is adequately sedated to allow passage of the endoscope into the nostril. Mild sedation allows the horse to maintain a good swallow reflex. Use of a drop nose cavesson will decrease chewing action and may facilitate swallowing of the scope, but will not completely prevent a horse from being able to damage a scope by chewing on it. To do a gastroscopic examination, the veterinarian should manipulate or drive the scope. An assistant should pass the scope, and a third person should handle the horse. The assistant, referred to as the passer, should stand on whichever side suits their technique for nasogastric intubation. The system is placed on the opposite side so that the monitor is facing the passer. It is important for the passer to easily see the monitor during the exam. To minimize risk of damage to the scope, the passer should watch the monitor to ensure the scope image advances, with each push of the scope into the nostril, except during the part of the procedure when the horse swallows the scope, where the passer should watch the horse's throat for the swallow. The veterinarian driving the scope stands in front, yet slightly to the side opposite the monitor. The handler, standing opposite the passer, should pay attention to the horse and not to the monitor. To lube the scope, moisten the first half meter with tap water. While I don't use lubricant during the procedure, if you choose to, do not apply the lubricant to the tip of the scope. It may cover the lens and obstruct the view. The scope is placed into the ventral meatus of the nasal passage and is advanced 30 to 40 centimeters into the nasal pharynx. Orienting the view relative to dorsal ventral positioning may facilitate the exam, but isn't necessary.
Shield the scope as it is brought to the nostril to avoid startling the horse with a bright light.
A cursory exam of the pharynx is performed, observing the guttural pouch openings, the dorsal pharyngeal recess, the epiglottis, the arytenoids, and the pharyngeal walls, noting any abnormalities. The scope is then advanced to a point just dorsal to the remiglottitis, almost touching the arytenoids. The passer drops their hand 10 centimeters down the scope and turns their attention to the horse's throat latch. Watching the throat latch instead of the monitor helps the passer coordinate advancement of the scope with the horse's swallow reflex. Because the view on the monitor may be obstructed during swallowing, or there may be a slight delay in the image depending on your system. While the passer advances the scope, the driver depresses the blue air water button to squirt water from the tip of the scope and blows into the tubing to help induce a swallow. The scope is only advanced until the passer's hand reaches the nares. The driver then insufflates and confirms the scope is in the esophagus.
If the horse has not swallowed the scope after 2 attempts, flushing a quick burst of water through the biopsy channel while simultaneously advancing will help the horse to swallow the scope.
Now that the scope is in the esophagus, the passer turns their attention back to the monitor and confirms that with each subsequent advancement with their hand, the scope image advances in the monitor view. Using this technique prevents the scope from being advanced enough to reach the molars should the scope retroflex into the oral pharynx during swallowing, or having the scope S-curve in the nasal pharynx and enter the oral pharynx during advancement with the tip already in the esophagus or in the stomach. Lubricate the scope body using tap water and advance to the stomach. The esophagus is not examined at this point, but will be examined during the scope removal. The driver descends the esophagus by holding their finger over the blue air water button. And air can also be added by blowing into the tubing attached to the biopsy port or using an external pump. If resistance to passing the scope is noted due to esophageal constriction, the scope can be retracted to the rostroesophagus and lubrication applied to the scope and repassed. In addition, a smooth muscle relaxant can be administered to relax the esophagus. In the average size horse, It will take about 1.8 to 2 meters to reach the stomach. Right at the cardia, it can get a little tight. Mild resistance may be encountered as the scope passes through the muscular cardiac sphincter. Gentle distension will facilitate passage into the stomach. The stomach should be distended until the rugal folds of the left wall and greater curvature disappear. Any excess fluid can be removed by suction, being careful to avoid getting fibrous material stuck in the biopsy channel, and the stomach can be distended again if needed. Once in the stomach, a quick survey of the fundus is performed, and the glandular fundus is examined. Images of ulcers noted during the exam should be captured by either still pictures or video. At this point, don't rinse off the fundic stomach walls. Instead, examine the pyloric antrum and duodenum first and the squamous mucosa second. Keeping the fluid levels low in the beginning of the exam will help in observing and entering the pyloric antrum.
Understand and mentally visualize the 3D anatomy of the stomach to facilitate passing the scope.
It may be difficult to enter the pyloric antrum. This is where understanding the anatomy of the empty and air-filled stomach in a three-dimensional way will help. The esophagus opens toward the right side of the horse, dorsal to the margoplicetus. Use the curve of the stomach to your advantage. Advance the scope in, contacting the right wall, and pass the scope along the right wall until you reach the greater curvature, staying dorsal to the margoplicetus. To facilitate this, keep a view where half of the monitor view is the right wall, which is on the left side of the screen, and half of the view is the lumen. Don't turn the scope too far out into the lumen or it will fall down. When the tip has reached the greater curvature, turn the scope so that the lesser curvature and cranial wall of the stomach are visualized. At this point, you will see the scope entering through the cardia. Advance the scope, knowing that you may encounter resistance as the tip of the scope is pushed into the greater curvature. Observing the scope advancing through the cardia ensures the scope has not S-curved in the pharynx, even though the scope tip may not be advancing. As more scope is pushed into the stomach, the resistance is overcome, and the tip will begin moving cranially. Slowly straighten the tip of the scope to maintain view of the lesser curvature and left wall as the scope bends through the greater curvature. Aim for the junction of the lesser curvature and the left wall, which is now on the left side of the screen. Maintain this view until the left wall is reached or the scope falls ventrally, and advance the scope along the left wall, keeping the half wall, half lumen view until it enters the pyloric antrum. If the scope falls below the fluid line, blow air through the scope to help see the left wall, and watch for a change in tissue character and color as the scope enters the antrum. Look dorsally to observe the curled under margoplicetus of the lesser curvature. This edge may not be easily seen during the later direct exam of the lesser curvature and is a common site of ulceration. As the scope is advanced along the fundic glandular mucosa and into the pyloric antrum, the mucosa will become smoother and lighter in color.
If you feel lost or you are stuck and cannot advance the scope, pull back and start over at the entrance to the stomach.
Once in the pyloric antrum, the scope can be retroflexed and the fundus of the stomach can be viewed in the background. The ventral shelf of the lesser curvature is seen as the dorsal limit of the antrum. The scope is redirected cranially and the pylorus is observed. Examine the glandular mucosa of the antrum. It should be light to medium pink and smooth. The rugal folds should flatten between peristaltic contractions. As you can see in this horse, a few small hyperemic areas are noted. To enter the proximal duodenum, The scope is turned to the left as it's advanced through the pyloric ring. The duodenal diverticulum can be examined, as well as the circumference of the duodenum in the area of the greater and lesser papillae of the common bile duct. I usually don't put much air, if any, into the duodenum. There's usually enough insufflation to see adequately. Greenish-brown bile is usually noted, and the duodenum mucosa should appear smooth. Once the antrum and the duodenum are examined, the scope is slowly pulled back into the fundus. As the slack is pulled from the fundus, it may push the scope cranially. The scope may actually advance further into the duodenum. As the scope is retracted through the antrum, the tip will move down into the ventral aspect of the fundus. Pull the scope back up into the air pocket within the fundus, so the tip is just extending through the cardia. At this point, the squamous and glandular mucosa of the fundus are examined in a systematic manner. Insufflate if rugal folds have reformed. Advance the scope slightly, turning the tip ventrally to observe the lesser curvature and that the fluid line is below the margo plicatus of the right wall lesser curvature junction. Begin the exam of the squamous mucosa with an end-on direct examination of the lesser curvature right wall junction. To achieve this view, repeat the same technique used to reach the pyloric antrum, but stop just as the scope tip reaches the left wall and before the scope falls. The scope will have been advanced about 30 to 35 centimeters into the stomach as noted at the cardia. In this view of the lesser curvature, the left wall is on the left side of the monitor. Pay particular attention to the right wall lesser curvature junction. This is the most common site of squamous ulceration, as it is the most ventral squamous mucosa. If gastric contents and/or mucus are present, they may be rinsed away to better view the stomach walls. This is more efficiently done using the 400 cc nylon dose syringe or garden sprayer and suction tubing versus a 60 cc syringe attached at the biopsy port. Once the lesser curvature is rinsed and examined, the scope is then retracted with the tip deflected and the lesser curvature examined close up. Using a combination of tip deflection, scope rotation, and scope insertion and retraction, the remaining squamous mucosa is examined in the following order: the left wall, the greater curvature, the right wall, and the dorsal saccus cecus. Turn the tip towards the left wall, the right side of the monitor, to inspect the squamous and glandular mucosa, following the margo plicatus along the left wall, rinsing as necessary. Advance the scope slightly while straightening to observe the greater curvature both above and below the margo plicatus. Squamous ulcers are often found here. While turning the scope to the right, the left side of the monitor, retract the scope to observe the right wall above and below the margo plicatus. Turn the scope dorsally to examine the dorsal saccus cecus. Once the examination of the stomach is complete, the stomach is deflated using suction. When the stomach is collapsed, the remaining negative pressure in the biopsy channel is relieved by pressing the red suction button on the handpiece. This normalizes the pressure in the scope and prevents collapse of the esophagus as the scope is withdrawn. The esophagus is examined as the scope is slowly withdrawn. It is easier to examine at this time as the folds tend to stretch away from the scope tip. It is important to document the relevant history and clinical signs in addition to the exam findings and treatment recommendations. To capture the information consistently, use a standardized comprehensive form.
Squamous ulcer locations should be noted, and ulcers graded according to the published Equine Gastric Ulcer Console 0 through 4 grading scale. Here are some examples of squamous findings.
Grade 0. The epithelium is intact and there is no appearance of hyperemia or hyperkeratosis. Grade 1. The mucosa is intact, but there are areas of hyperemia or hyperkeratosis. Grade 2. There are small singular or multifocal lesions. Grade 3. Ulcers are moderate to large, single or multifocal lesions, or extensive superficial lesions. Grade 4. Consist of extensive lesions with areas of apparent deep ulceration. Islands of glandular mucosa may be noted within the squamous mucosa, at or just dorsal to the margo plicatus. These may be normal for the horse or the result of a healed ulcer. To distinguish between a small ulcer, look closely for the lack of squamous defect or hyperkeratosis at the margin. The pink center closely resembles the glandular mucosa, just distal to the margo plicatus, and is not a wound bed or granulation tissue.
Glandular ulcers should be described as recommended in the European College of Equine Internal Medicine Consensus Statement, Equine Gastric Ulcer Syndrome in Adult Horses, published in the Journal of Veterinary Internal Medicine.
Glandular ulcers should not be graded, but described based on anatomic location, distribution, severity, and appearance. Anatomic locations include cardia, fundus, antrum, and pylorus. Duodenal lesions should also be described. Distribution is described as focal, multifocal, and diffuse. Severity is characterized as mild, moderate, and severe. Appearance refers to the combined epithelial appearance and mucosal contour. Epithelial appearance descriptors include hyperemic, hemorrhagic, fibrinosuppurative, and ulcerated. Mucosal contour descriptors are depressed, flat, and raised. Using this terminology, the lesions are described as one of 6 lesion types: flat and hyperemic hemorrhagic, flat and fibrinosuppurative, raised and hyperemic hemorrhagic, raised and fibrinosuppurative. Depressed plus or minus blood clot. Depressed and fibrinosuppurative.
To recap, a complete exam of the horse's stomach includes observing the fundic, squamous, and glandular mucosa, the pyloric antral glandular mucosa, the pyloric ring, the proximal duodenum, and the esophagus. The advantages of gastroscopy are to allow the veterinarian to definitively determine the presence and severity of ulcers, as well as determine the area of the stomach affected. Knowing this information will help develop an appropriate treatment protocol and prognosis.